We will be starting with section 5 of your Apurba Sastry Essentials of Microbiology, which is gastrointestinal infections. In this unit, we will be covering the chapter 39 to 46, which 39 chapter is gastrointestinal infective syndromes. 40 is food poisoning by Staph aureus, Bacillus cereus, Clostridium botulinum, and others. Gastrointestinal infection due to Enterobacteriaceae, diarrheogenic E. coli, shigellosis, non-typhoidal salmonellosis, and yersiniosis will be in chapter 41. Chapter 42 will be about cholera, halophilic vibrio, and Aeromonas infections. 43 will be about miscellaneous bacterial infections of gastrointestinal system, Helicobacter, Campylobacter, and Clostridium difficile infections. 44th will be about viral gastroenteritis, rotavirus, and others. 45th will be about intestinal protozoan infection, intestinal amoebiasis, giardiasis, coccidian parasitic infections, balantidiasis, blastocytosis, and others. 46th chapter will be about intestinal helminthic infections, which will cover the intestinal cestode infection by Diphyllobothrium, Tinea, Hymenopolopsis, and others. Intestinal trematode infections like Fasciolopis busci, Schistosoma mansoni, Schistosoma japonicum, and others, and intestinal nematode infections like Trichuris, Enterobius, hookworm, Strongyloides, Ascaris, and others. So this is about prevention of diarrheal diseases. The WHO recommendations: first is safe water, adequate sanitation, treat water before use and dispose of waste safety. Next is improved hygiene, wash hands when appropriate. Routine vaccination to provide rotavirus vaccine. Exclusive breastfeeding for the first 6 months. Good personal and food hygiene, and health education about how the infection spread. So let's start with the chapter 39, which is gastrointestinal infective syndromes. In this, we'll be having a general overview about whatever infections happen in the GIT. In this chapter, we will be previewing the resident microbial flora, diarrheal disease, and other infective syndromes of GIT. Gastrointestinal infections are the most commonly encountered infective syndromes in man. At the same time, the human gastrointestinal tract colonizes a number of resident microflora, which also provides several beneficiary effects. So let's talk about the resident microbial flora. Human GIT is colonized by a diverse group of normal resident microbial flora. Upper GIT contains only sparse flora, streptococci in oral cavity and lactobacilli in the stomach. Lower GIT, the microbial load gradually increases towards the lower part of GIT and is the highest in the distal ileum, 10 to the power 11 to 10 to the power 12 per gram. The large bowel comprises of both anaerobes and aerobes with the ratio of 1,000:1, with bacteroids fragilis most common and Enterobacteriaceae such as E. coli, Klebsiella present predominantly. Normal flora also comprises yeast, example Candida, and parasites like Entamoeba coli. Normal GI flora has several benefits such as preventing the colonization of pathogens in the intestine, synthesizing various vitamins, modulating the immune system, etc. So in this table we can see, these are the gastrointestinal infective syndromes. What are these? Diarrheal diseases like diarrhea, dysentery, traveler's diarrhea, persistent diarrhea, gastroenteritis, and food poisoning. Other gastrointestinal infective syndromes like acute vomiting, necrotizing enteritis, pseudomembranous enterocolitis, tropical spure, peptic ulcer disease, infections of other GI structures such as appendicitis, diverticulitis, and typhlitis. Okay, so let's discuss these one by one. First, the diarrheal disease. The diarrheal disease are one of the leading cause of illness globally, cause significant morbidity and mortality. It is more common in developing countries where the young children get diarrhea on average 3 times a year. Worldwide, about 1.7 to 5 billion cases of diarrhea occur per year, with 1.26 million deaths, accounting for the second leading cause of death globally. There are various clinical types of diarrheal diseases, as we have seen, caused by a wide variety of infectious agents, including bacteria, virus, and parasites. First comes diarrhea. Diarrhea is defined as passage of 3 or more loose liquid stools per day in excess than the usual habit of the person by WHO. It may be caused by microbial infections or as a result of other gastrointestinal diseases such as inflammatory bowel disease, celiac disease, etc. Acute diarrhea usually lasts for less than 14 days, most often caused by viral agents followed by bacterial or parasitic agents. Common microbial agents causing diarrhea will see in the table. Dysentery. Dysentery is characterized by diarrhea with increased blood and mucus, often associated with fever, abdominal pain, and tenesmus, feeling of constant need to pass stool despite an empty colon. Next, the traveler's diarrhea. Traveler's diarrhea is the most common travel-related infectious disease. Epidemiology, it occurs in about 20 to 50% of people traveling from temperate industrialized countries to tropical regions of Asia, Africa, and Central and South America. Clinical presentation, most cases begin with first 3 to 5 days, characterized by sudden onset of abdominal cramps, anorexia, and watery diarrhea. The illness is generally self-limiting, lasts for 1 to 5 days. Microbial agents causing travelers diarrhea are listed in the table. Overall, enterotoxigenic E. coli is the most common agent, followed by enteroaggregative E. coli. Campylobacter jejuni is more common in Asia. Norovirus diarrhea associated with traveling on cruise ships. Next is the persistent and chronic diarrhea. Diarrhea that lasts for more than 14 days, usually 2 to 4 weeks, is considered persistent. Chronic diarrhea usually lasts for more than 4 weeks. Okay, may result from infections due to various organisms. Parasites like Cryptosporidium, Cyclospora, and Amoeba histolytica giardia account for a major cause of chronic diarrhea. Bacteria Aeromonas, Campylobacter, Clostridium difficile, and Plesiomonas. Viruses such as cytomegalovirus, common in immunocompromised host. Fungi such as Microsporidia, common in immunocompromised host. Chronic diarrhea may also result from various non-infectious etiologies such as pancreatic disorders, intestinal disorders, example colitis, Crohn's disease, irritable bowel syndrome, or tumors. So now let us look at these tables. First table is about the infectious agents of acute diarrhea and underlying mechanism. Okay, so non-inflammatory mechanism features are located in proximal small bowel, illness, watery diarrhea, stool findings are no fecal leukocytes, fecal lactoferrin not increased or mildly increased. Examples of pathogens involve bacteria, most enterotoxin mediated, Vibrio cholerae, E. coli, enteropathogenic, non-toxigenic, enterotoxigenic, and enteroaggregative. Clostridium perfringens, Bacillus cereus, Staphylococcus aureus, Aeromonas hydrophila, Plesiomonas sigilosis, viruses rotavirus, norovirus, enteric adenovirus 4041, calcivirus, astrovirus, fungi microsporidia. Parasite protozoa Giardia lamblia, Cryptosporidium parvum, Cyclospora cytensis, Cystiospora belli, and Blastosis hominis. Parasites like Ascaris lumbricordis, hookworm, Strongylides stereocolis, Enterobius vermicularis, Trichinella spiralis, Tinea saginata, Tinea solium, Hymenopsis nana, Diplydium caninum, Diphyllobothrium latum, and Fasciolopsis busci. Now the inflammatory diarrhea, invasion or cytotoxin. The location is colon or distal small bowel. Illness is dysentery or inflammatory diarrhea. And stool findings are fecal pus cell polymorphonuclear leukocytes increased and fecal lactoferrin markedly increased. Predominantly dysentery. Shigella species, Campylobacter jejuni, enterohemorrhagic E. coli, enteroinvasive E. coli, Vibrio parahemolyticus. Predominantly inflammatory diarrhea, non-typhoidal salmonella, Yersinia enterocolitica, Listeria monocytogenes, Clostridioides difficile, Plesiomonas shigelloides, Klebsiella oxytoca. Parasite predominantly dysentery, Entamoeba histolytica, Balantidium coli, Trichuris trichuria, Schistosoma mansoni, and Schistosoma japonicum. Now the penetrating location, distal small bowel, illness, enteric fever, stool findings, fecal mononuclear leukocytes, Salmonella typhi, enteric fever, and Yersinia enterocolitica, typhoid-like illnesses caused. Note, there are a number of organisms transmitted through the enteric route but predominantly cause extraintestinal manifestations and therefore are discussed in their respective systems where they predominantly cause infection, for example Salmonella typhi and bloodstream infections. And Enterobius vermicularis causes perianal pruritus, not diarrhea. Okay. Now let's see the agents causing travelers diarrhea. Etiologic agent for bacteria 50 to 75%, enterotoxigenic E. coli 10 to 45%, single most important agent. Enteroaggregative E. coli 5 to 35%, emerging enteric pathogen with worldwide distribution. Campylobacter jejuni more common in Asia. Shigella non-invasive, entero-invasive E. coli, major cause of dysentery. Non-typhoidal salmonella, common agent in India. Others including Aeromonas, Plesiomonas, and Vibrio cholerae. Viruses less than 20%, norovirus less than 10% associated with cruise ships, rotavirus less than 5% common among children. Parasites 0 to 10%, Giardia, Lamblia, Cryptosporidium, and Amoeba histolytica, Cyclospora. Okay. Now the pathogenic mechanisms of diarrheal agents: toxin production, enterotoxin, cholera toxin, Vibrio parahemolyticus E. coli, LT and ST of ETEC, East of EAEC, VT of EHEC, Clostridioides difficile toxin A, Aeromonas, rotavirus, NSP4, and Campylobacter jejuni. Cytotoxins secreted by Shigella dysentery type 1, enterohemorrhagic E. coli, Clostridioides difficile toxin B. Neurotoxin, Staphylococcus aureus enterotoxin, Bacillus cereus toxin, Clostridium botulinum toxin. Attachment with or close to mucosal cells, E. coli enteropathogenic, enterohemorrhagic, Cryptosporidium species, Cyclospora species, Cystiospora species, rotavirus, and norovirus. Invasion of intestinal epithelium, Shigella species, enteroinvasive E. coli, Campylobacter jejuni, Yersinia enterocolitica, Plesiomonas shigelloides, and Amoeba histolytica, and Valentidium coli. Okay, so now we start with gastroenteritis. Gastroenteritis or infectious diarrhea may be defined as an inflammation of the mucous membrane of the stomach and intestine, resulting in combination of diarrhea, vomiting, and pain abdomen with or without mucus or blood in stool, fever, or dehydration. Food poisoning refers to an illness acquired through the consumption of food or drink contaminated either with microorganisms or their toxins. It is discussed later. The pathogenic mechanisms. Enteric pathogens have developed a variety of strategies to overcome host defenses. Inoculum size. Enteric pathogens differ from each other in their infective dose, minimum dose required to initiate the infection. For example, Shigella, enterohemorrhagic E. coli, Giardia, and Amoeba histolytica, 10 to 100 bacteria or cysts are sufficient. For Vibrio cholerae, 10 to power 5 to 10 to power 8 bacilli. For Salmonella, 10 to power 3 to 10 to power 5 bacilli. Now the adherence. Adherence to intestinal mucosa helps the organism to compete within the normal bowel flora and thereby colonizing the intestinal mucosa. This is crucial for pathogenesis of many diarrheal agents such as enteropathogenic E. coli, enterohemorrhagic E. coli, enterotoxigenic E. coli, and Vibrio cholerae. Toxin production. Enteric organisms can produce a variety of toxins which are implicated in pathogenesis of diarrhea. These include enterotoxin, cause watery diarrhea by acting directly on the secretory mechanisms in the intestinal mucosa. Cytotoxin cause destruction of mucosal cells leading to inflammatory diarrhea. Neurotoxin act directly on the central nervous system producing vomiting. Invasion. In addition to production of toxin, bacterial invasion is another mechanism by which destruction of intestinal mucosal cells takes place in dysentery. Predisposing factors. Alteration of the host defense mechanisms can promote the diarrheal diseases. Suppression of the normal flora leads to loss of protective effect of intestinal microbiota. They usually prevent colonization by potential enteric pathogens. Neutralization of gastric acidity promote the acid labile pathogens, example Vibrio cholerae. Inhibition of intestinal motility interfere with the clearance of the bacteria from the small intestine. Aged children less than 5 years are more likely to contract most of the diarrheal diseases, example rotavirus, than adults. Children are most commonly affected in the weaning period called as weaning diarrhea. This may be caused because of unhygienic food preparation during weaning. Another reason is breastfed infants are usually protected due to maternal antibodies. However, older children and adults are more commonly affected with novovirus diarrhea. Location. Closed and semi-closed communities including daycare centers, school, residential facilities, and cruise ships are among the most important settings for the outbreaks of diarrheal diseases. Antibiotic associated. Patients on prolonged antibiotic course are more likely to develop Clostridium difficile infection leading to diarrhea. Impaired host immunity. Immunocompromised hosts are at a higher risk of developing diarrhea. Individuals with AIDS are at high risk for various invasive diarrheal illness such as salmonellosis, cryptosporidosis, etc. Individuals with hypogammaglobulinemia are particularly at high risk for Clostridium difficile colitis and giardiasis. Genetic determinants. Host genetic variation influences susceptibility to diarrheal diseases. People with blood group O show increased susceptibility to diseases due to Vibrio cholerae, Shigella, E. coli, O157, and norovirus. Now comes the lab diagnosis. First, specimen collection. Fecal specimen containing mucus flakes is collected in a sterile screw-capped wide mouth container. In carriers, a rectal swab may be collected. Specimen should be transported to the laboratory within 1 hour. If a delay of longer than 1 hour is anticipated, the fecal specimen should be collected in transport media like Carey Brayer medium or alkaline peptone water if cholera is suspected. Macroscopy. The following macroscopic appearances are noted. Color of the specimen, consistency of the specimen, formed, semi-formed or liquid. Presence of blood, suggestive of dysentery, mucus or pus suggestive of inflammatory diarrhea. Presence of adult parasitic forms, example Enterobius, Ascaris or Tinea segments. Microscopy. Wet mount preparation in saline or iodine is done for detection of pus cells, RBCs and detection of parasitic cysts, trophozoites, eggs or larvae. Hanging drop preparation. It is done for liquid specimens to demonstrate darting motility of Vibrio cholerae. Gram stain smear. Gram staining of stool specimen is not routinely done because of the presence of normal flora. It is recommended only in special situations where the typical morphology would suggest preliminary clue for diagnosis. Presence of gram-negative comma-shaped bacilli Vibrio cholerae. Gram-positive budding oval yeast cells in immunocompromised host or in infant suggestive of Candida species. Modified acid-fast staining with 0.5 to 1% sulfuric acid can be carried out for the detection of oocytes of Cryptosporidium, Isospora and Cystoisospora. Electron microscopy of stool specimen can be performed for detection of morphology or specific viruses causing gastroenteritis. Rotaviruses appear as spokes grouped around the hub of a wheel. Astroviruses have a star-like morphology. Coronaviruses have cup-like depressions on the capsid surface. Bacterial culture. Culture media fecal specimen should be inoculated into the following media. Enrichment broth, selenite F broth and alkaline peptone water. Mildly selective medium McConkey agar. Highly selective medium such as DCA deoxycholate citrate agar, XLD xylose lysine deoxycholate agar, and DCBS thiosulfate citrate bile salt sucrose agar. Sorbitol McConkey agar when outbreak of E. coli O157 is suspected. Identification. Identification of the enteric pathogens is made by performing either conventional biochemical test or automated methods such as MALDI-TOF or Whitec. Then serotyping is performed with specific group or type specific antisera. Antimicrobial susceptibility test is done to choose appropriate drug for treatment. This diffusion test is carried out on Muller-Hinton agar. Tissue culture. It is carried out for the detection of enteric viruses and also for some diarrheogenic E. coli. Enterotoxigenic E. coli ETEC penetrates HeLa and HEP2 cell line, whereas verocytotoxin of enterohemorrhagic E. coli HEC is detected by cytotoxic effect on vero cell line. Antigen detection. Various test formats are available to detect microbial antigens in stool. ELISA is available for detection of rotavirus antigen in stool. Identification features or detection methods of common organisms causing acute diarrhea or dysentery. First comes the Vibrio cholerae, causes watery diarrhea. Identification features darting motility, comma-shaped gram-negative bacilli and culture smear. TCBS agar sucrose fermenting yellow-colored colonies. Identification by conventional biochemical tests or automated methods like Whitec or MALDI-TOF. Agglutinates with Vibrio cholerae O1 antisera and Ogawa antisera. This is the most common pattern, though other serotypes are also present. Shigella causes dysentery. Gram-negative bacilli non-motile MAC or DCA medium non-lactose fermenting translucent colonies. XLD red colonies without black center. Identification by conventional biochemical test for automated methods like Whitec or MALDI-TOF. Agglutinates with Shigella polyvalent antisera and specific monovalent antisera. Group B Salmonella cause inflammatory diarrhea. Gram-negative bacilli motile MAC non-lactose fermenting translucent colonies. DCA non-lactose fermenting colonies with black center. XLD red colonies with black center. Identification by conventional biochemical test or automated methods like Whitec or MALDI-TOF. Agglutinates with Salmonella poly O antisera and serotype O4 specific antisera. Viral agents. Diarrhea. Agents rotavirus, norovirus, adenovirus 4041, etc. Detection of viral particles in stool specimen by electron microscopy. Detection of viral antigen by ELISA, or detection of nucleic acid, RNA or DNA by PCR in stool specimen. Intestinal parasites. Entamoeba histolytica causes dysentery. Stool microscopy detects trophozoites and or quadrinucleated round cysts. Detection of specific antigen, example lectin, or specific centers in stool. Giardia intestinalis, fatty diarrhea. Trophozoites teardrop shaped binucleated with four pair of flagella and or tetranucleated oval cyst with a central axoneme. Trichuris, dysentery. Barrel shaped eggs with mucus plugs at both ends, bile stain. Enterobius vermicularis, nocturnal anal pruritus, plano-concave egg containing larva, non-bile stained. Ascaris lumbricoides, malabsorption, fertilized egg round oval thick albumin coat floats in saturated saline bile stain. Unfertilized egg elongated thin albumin coat does not float in saturated saline bile stained. Hookworm, diarrhea, anemia. Egg, oval contains segmented ovum with 4 blastomeres non-bile stained. Strongyloids, diarrhea, detection of rhabdiform larva in stool microscopy. Abbreviations: TCBS, thiosulfate citrate bile salt, sucrose agar, MAC, McConkey agar, DCA, deoxycholate citrate agar, XLD, xylose lysine deoxycholate agar, ELISA, enzyme link immunosorbent assay, PCR polymerase chain reaction. Now, continuing the antigen detection, rapid tests such as immunochromatographic test is available for simultaneous detection of antigens of three parasites: Entamoeba histolytica, Giardia, and Cryptosporidium in stool. Latex agglutination test is available to detect E. coli in O157 antigen in stool. Rapid test is available to detect Clostridium difficile antigens, glutamate dehydrogenase, and toxin A or B in stool. Molecular methods. Several molecular method test formats are available for the detection of gastrointestinal pathogens. Polymerase chain reaction PCR assays can be carried out for the detection of specific genes of enteric pathogens. Biofar film array. It is a fully automated commercial nested multiplex PCR. Its gastrointestinal panel is used to detect common bacterial, viral, parasitic, and diarrheal pathogens. Other methods, methylene blue preparation, can be performed in unformed stool to detect fecal leukocytes, which is suggestive of inflammatory diarrhea. Fecal lactoferrin detection is also suggestive of inflammatory diarrhea. Fecal lactoferrin is an iron binding protein found inside the neutrophils. The amount of lactoferrin released by neutrophils has been shown to correlate with the severity of intestinal inflammation. Treatment. Treatment depends upon the severity. Fluid therapy rehydration is the mainstay of the treatment. Antimotility agents and adsorbents may be considered in moderate to severe diarrhea. Empiric antibiotic therapy is required only for severe diarrhea. Now we see the table. Treatment for diarrheal diseases adapted from Stanford guideline. Types of diarrhea. Mild diarrhea. 1 to 2 unformed stools per day. Minimal symptoms. No interference with daily routine activities. Treatment: hydration fluids, lactose free diet, and avoid caffeine. No antibiotics required. Moderate diarrhea. 3 to 5 unformed stools per day with or without symptoms. Interfere with daily routine activities. Fluids plus antimotility agents, loperamide plus adsorbents, bismuth subsalicylate. No antibiotics required. Severe diarrhea. More than 6 unformed stools per day plus minus temperature more than equal to 101 degree Fahrenheit, tenesmus, blood or fecal leukocytes. Treatment: empirical ciprofloxacin or levofloxacin for 3 to 5 days. Alternative: azithromycin for 3 days for Campylobacter and metronidazole or vancomycin for 10 to 14 days for Clostridium difficile. Now coming on to other infectious syndromes of GIT. Acute nausea and vomiting. Although nausea and vomiting are the part of manifestation of many of the diarrheal illnesses, there are few infectious conditions where acute nausea and vomiting are the main clinical features. Food poisoning due to agents with short incubation period like Staph aureus and Bacillus cereus, emetic type, chiefly present as acute onset of nausea and vomiting within 6 hours of ingestion of food contaminated with toxins. Winter vomiting disease, also called gastric flu, is a clinical condition presenting with abdominal discomfort, vomiting, and or diarrhea. It commonly occurs in winter months in temperate climates, although etiologic agents are rarely identified. Studies have shown that certain caliciviruses such as norovirus, Norwalk virus, and Sepovirus have been commonly implicated. Necrotizing enterocolitis. Necrotizing enterocolitis is a fulminant disease that affects typically the premature infants and accounts for major cause of mortality in the low birth weight infants. It is characterized by necrosis of bowel wall with mucosal slowing, the most common site being the terminal ileum. This devastating syndrome often leads to intestinal perforation, peritonitis, and bacteremia. The agents that are commonly implicated include Pseudomonas, Klebsiella, certain E. coli strains EPEC serotype 0111B4, Salmonella, Clostridium perfringens, and Clostridium butyricum. Necrotizing enteritis, it is also called as enteritis necroticans, gas gangrene of the bowel. It is a life-threatening condition characterized by ischemic necrosis of the jejunum and gas in tissue plane. It is also called as pig bell in Papua New Guinea and Darmbrand in Germany. It is caused by Clostridium perfringens type C strains producing beta toxin. Clostridium perfringens predominantly causes skin and soft tissue infection, gas gangrene. Pseudomembranous enterocolitis. This condition is produced by Clostridioides difficile, which typically occurs in patients on prolonged therapy with broad spectrum antimicrobials. It is characterized by formation of pseudomembrane on colonic mucosa, which are whitish yellow plaque of size ranging from 1 to 2 mm spread over the colonic mucosa. Tropical spure. It is a malabsorption disease commonly found in tropical regions characterized by malabsorption of at least two distinct nutrients, abdominal duodenal histopathology, abnormal flattening of villi, and inflammation of the endothelial lining, and weight loss. Epidemiology. It is most frequent in Asia and Caribbean islands, common in adults than children, usually affects the long-term travelers to endemic regions. Etiology. Though the etiology is not clear, there is strong presumption that it is caused by enteric infections, perhaps in individuals predisposed by some nutritional deficiency such as folic acid. Patients often show increased small bowel growth with various gram-negative rods including alkaligins, Enterobacter, Klebsiella, E. coli, and Enterobacter, etc. Treatment includes folic acid and tetracycline. Esophagitis. Infections in the mucosa of esophagitis can cause painful or difficult swallowing or the sensation that something is lodged in the throat while swallowing. Individuals who have esophagitis usually have local or systemic underlying illnesses such as hematologic malignancies or HIV infection, or they are receiving immunosuppressive therapy. The most common etiologic agents are Candida species, primarily Candida albicans, herpes simplex virus, and cytomegalovirus. Seventh is gastritis. Gastritis refers to inflammation of the gastric mucosa. This illness is associated with nausea and upper abdominal pain, vomiting, burping, and fever may also be present. Helicobacter pylori is associated with majority of cases recovered from gastric biopsy. H. pylori is also the causative agent of peptic ulcer disease, formation of ulcers in the stomach and duodenum, and is a significant risk factor for the development of gastric cancer. Peptic ulcer disease presents with epigastric pain with burning sensation. It is most common symptom, classically occurs in an empty stomach with gastric ulcers and 2 to 3 hours after food intake in duodenal ulcers. 8. Appendicitis. Appendicitis is an acute inflammation of the vermiform appendix leading to complications such as intestinal obstruction, perforation, peritonitis, and intra-abdominal abscesses. It usually affects adolescence and early adulthood. The infection is usually polymicrobial, frequently involving aerobic and anaerobic gram-negative bacilli. Diagnosis is usually made clinically, supported by ultrasonography. Surgical removal of the appendix provides the definitive treatment. Adjunctive use of broad-spectrum antibiotics may also be required. Diverticulitis. It is characterized by inflammation of abnormal pouches, diverticula, which can develop in the wall of the large intestine. It may be associated with polymicrobial infection. Typhlitis, also called as neutropenic enterocolitis, it refers to inflammation of the cecum associated with polymicrobial infection such as enteric, aerobic, and anaerobic organisms, including Clostridium, Enterococcus, Enterobacteriaceae, Pseudomonas aeruginosa. Use of cytotoxic chemotherapeutic agents is the most common predisposing factor. 11th, proctitis. Proctitis is the inflammation of the rectum, presents with itching and mucus discharge per rectum, which subsequently progresses to formation of ulcers and abscesses in the rectum. The majority of infections are sexually transmitted through anal intercourse. Chlamydia trachomatis, herpes simplex virus, Treponema pallidum, and Neisseria gonorrhoeae are the common etiologic agents. 12th, Whipple's disease. Tropirma whippeli. It is a rare disease affecting small intestine and also other organs such as CNS and endocardium, caused by gram-positive actinomycetes called Tropirma whippeli. Manifestation involves impaired breakdown of food such as fats and carbohydrates and decreased ability to absorb nutrients. Common symptoms include fever, abdominal pain, diarrhea, weight loss, and migratory polyarthralgia. Mesenteric lymph nodes are primarily involved. Lab diagnosis. Histopathological staining of intestinal biopsy shows prominent macrophage infiltration, fat deposition, and characteristic pathognomic vacuoles within the macrophage containing periodic acid shift pass stain positive bacilli. PCR targeting 16S ribosomal RNA can be done to identify the bacilli. Culture of T. vipelli has been unsuccessful. Treatment comprised of doxycycline and hydroxychloroquine given for 1 year followed by lifelong doxycycline. Relapse may be seen up to 40% of the cases which receive incomplete treatment less than 1 year. Okay, now there are some case scenarios. A 6-year-old boy developed severe watery diarrhea and vomiting since 2 days. Stool collected has rice water type of appearance. On inquiry, it was found that two members of the same family and few children of the same locality also suffered from similar presentations. So this is clearly a case of cholera, and we can write the whatever the microscopy and the culture techniques are used. In the second case scenario, an outpatient department, a 2-year-old child presented with tenesmus, abdominal pain, and passage of bloody diarrhea with mucus 8 times for past 2 days. So this can be a case of shigellosis. Okay, now the questions: what the probable diagnosis, the etiological agents, pathogenesis, clinical manifestations, the lab diagnosis, and the treatment modalities. You can write according to the detailed study. Okay, like, share, subscribe. Thanks for watching.